Hello, everyone, and welcome to Air Care Alliance webinar, Passenger Flights in the Wake of COVID-19. Where do we go from here? Many volunteer pilot organizations have suspended passenger carrying flights recently, and as restrictions lift, it's more important than ever to understand how COVID-19 affects the way pilots and organizations move forward. Our webinar today is intended to answer your questions and to address issues that are faced by volunteer pilot organizations during this pandemic. Please note that this webinar is being recorded and you will have the opportunity to watch it again and to share it with others. We are honored and fortunate to have a panel of incredible experts with us today to help inform this important discussion. Dr. Hunter Hansfield is board certified in infectious diseases and spent a 40-year career with public health. He is Professor Emeritus of Medicine at the University of Washington School of Medicine and has been involved in development of policies and procedures in response to the current pandemic. He is also a volunteer pilot and former board member for Angel Flight West. He flies a turbocharged 182 with over 3,700 hours of flight time. Dr. Shema Kazmi is a medical oncologist and hematologist with Cancer Treatment Centers of America. She focuses on the treatment of thoracic malignancies, such as lung cancer and head and neck cancers, and also extensively treats breast cancer. She has conducted numerous cancer research studies and has given many lectures on topics such as genomic testing, immunotherapy, and integrative cancer treatment. Dr. Daniel Macy is the medical officer for the California Disaster Area Response Team. He is board certified in internal medicine, hematology, and medical oncology, and he served 12 years as a Navy medical officer and subsequently in U.S. Public Health Service. He is a retired professor of medicine at UC San Diego School of Medicine and Vanderbilt University Medical Center. He is also a pilot with over 3,200 hours of pilot in command time, flying an RV-10. And Dr. Daniel Slane is a family physician and the regional medical director of the Americas for International SOS, the world's leading medical and travel security services company, overseeing well over 1,000 daily cases pre-COVID-19. He has played a leading role in managing outbreak responses to COVID-19, Ebola, MERS, SARS, and Zika. He proudly serves as a board member for Angel Flight East. And I am Christina Luke. I am the executive director for Air Care Alliance. I'll be your moderator for today's panel discussion. I'd like to mention that all of our panelists today are here as volunteers and taking time out of their busy schedules to be with us. Dr. Kazmi is actually squeezing us in between patients today and may need to drop off a bit early, but we are very grateful for all of our panelists today and their time. Many of you have already submitted questions to us, so thank you for that. We'll do our best to get through as many of those today as we can. And we'll also be taking questions along the way. So if you have a question, you can go ahead and submit that through the Q&A button on your control panel. We've got a lot to cover today, so let's try to get right into it. You know, many of you watching may be familiar with the white paper that was co-authored by Dr. Macy and Dr. Hansfield entitled COVID-19 Effects on Volunteer Pilot Operations. Air Care Alliance had distributed that widely, and AOPA had printed it as well. Both Dr. Hansfield and Dr. Macy have subsequently provided their thoughts on this topic of resuming passenger flights. So I'd like to start there. Dr. Hansfield, are you with us? We're still not getting some audio there. While he works that out, can we start maybe with Dr. Macy? Tell us a little bit about your viewpoint on resuming passenger flights.
Okay, yes. Well, so I'm proud to have the privilege to participate, and was looking forward to the opportunity of providing a little supplementary commentary to Dr. Hansfield's new paper on resuming passenger carrying operations. So all I would have to do is put a little icing on the cake. But what I can do, I think, is frame a pretty dramatic change in the focus of our concerns that has occurred as new knowledge about the virus and the extent of the pandemic has accumulated very rapidly over the last 6 to 8 weeks. I reflected that our first paper was a very long laundry list of potential risks and concerns, all of which were kind of equally concerning or threatening back in those days. But now I think we have confidence that the major mode of transmission of the virus is person to person via respiratory pathways, and that among those respiratory pathways, the most frequent of them is so-called droplet based, and that is the normal stream of droplets that come out of our mouths when we cough or sneeze or speak. And droplets in a medical context are known for their predictable property of falling to the ground. So they have enough weight that they fall out of the air. Oop, I think we're seeing Hunter now.
And how are you hearing me?
All right.
All right.
We can hear you, and I'd be happy to pass the baton, and hoping I didn't do any violence to the truth in my short introductory remarks.
I apologize to everybody. I wasn't able to hear it as I was switching computers. I'll have to figure out what's going on with the other one. But thank you all for your attendance and so on. So Dan, in one sentence, how far along did you get?
I was only saying that actually the emphasis of concern about transmission is focused now on droplet-based person-to-person respiratory spread.
Got it. So I'll take just a couple of minutes, and I'm essentially going to summarize the main points in the newer essay that you should now have been distributed, should have gotten from Chris, and is also available online and so on. And it's simply a thought about where we go here as the rest of the country starts to open up. Where should the mostly closed down volunteer pilot organizations and general aviation where should we go now? I made a couple of points in this essay. First is that it is becoming clear that although airborne transmission does occur, and there are some well-publicized events that indicate it, in most healthcare settings, healthcare providers are not getting infected. And for the most part, for example, in a study not yet published at the University of Washington, in which 2,300 healthcare personnel raised basically 4 medical centers in the Seattle area, of whom about 60% had direct patient contact and 40 or so percent had other jobs in the medical centers that didn't involve patient care. And those two groups, the ones who were providing care and those who are not, have identical rates of COVID infection. Around 4% were infected during a 1-month period covering March through the first part of April. In the university system, the providers do not take aerosol precautions. They do not use N95 masks or high filtration masks or independent air supplies, except when doing procedures that are known to generate aerosols, floating particles that could infect. In other words, they are protected by what amounts to the medical equivalent of surgical masks plus non-touching and that sort of thing. So there are clearly airborne transmission can occur, but it appears, and the other indirect evidence that droplet precaution from sneezing, coughing, and that sort of thing account for most infections in the community is witnessed by the very fact that new infection rates are declining quite dramatically, particularly in those metropolitan areas that started social distancing and mask wearing promptly, such as Seattle and others. So the fact that community-based droplets are larger particles that settle out of the atmosphere quickly. Aerosols are finer ones that circulate in the air. But droplet precautions seem to help an awful lot. Now the question comes up, what about an aircraft environment? And Dan, you have made the point, and I agree, that the 6-foot distancing criterion is basically intended for one-time brief exposures as opposed to continuous exposure for an hour, 2 hours, 3 hours in an enclosed space like an aircraft cockpit. On the other hand, since wearing masks appears to be very helpful and protective, and most general aviation, smaller general aviation aircraft probably have fairly high air circulation and turnover, I'm not convinced that the environment in a cockpit is necessarily highly risky. What clearly needs to be done, though, is to first take steps as far as possible to exclude infected people from boarding. I think it's probably only a matter of weeks or a couple months before we can have more readily available and perhaps rapid testing that will allow us to make a conclusive determination. In the meantime, if you think about it, in even the most heavily affected communities, only a couple of % of people, for the most part, are likely, maybe 1% or less, are likely to be carrying the virus at any point in time. And if you exclude those who are actively coughing by asking about symptoms, and exclude those who are at particularly high risk because they've known to be exposed or traveled to an infected area, you can drop that 1% likelihood that someone is infected and boarding your aircraft to well below 1%. Adding that low statistic to a probable low rate of transmission in the air, even before we can use testing to definitively exclude infected folks, probably provides a high degree of safety. A high degree does not mean zero risk. And the dilemma facing Air Care Alliance and volunteer pilot organizations and the like is, what level of security do the organizations want to assume on behalf of their pilots, and what do the pilots want? I put this in the context of pilot in command responsibilities. As PICs, we all make decisions about every flight, whether it's, and all the standard stuff is pilot health and weather and terrain and pilot capabilities and all that stuff. We now need to add coronavirus prevention as another PIC responsibility, and each pilot should be authorized to make his or her own decisions, and ACA and VPOs probably should think about what general guidelines they want to provide, knowing the risk cannot be zero. The last point I'll make is that, in my personal opinion, volunteer pilot organizations and others should not have restrictions that are more stringent than those that otherwise apply to the people they serve. And the example I give in this essay is for example, those VPOs that provide healthcare needs. And I'm thinking of the angel flight organizations, for example, and there are also others. As social distancing, as things start to open up, as healthcare providers in general start to provide non-emergent care, which has largely been shut down, I don't think that the VPOs that facilitate that care by getting people to long-distance medical appointments should have more restrictive policies than the healthcare providers themselves. So if the medical centers providing that care are comfortable with the screening out, screening for symptoms, using masks and that sort of thing, and avoiding personal contact like hugging, kissing, shaking hands, then it seems to me that VPOs might take a position that is analogous to that and not necessarily any more stringent than that. So I'll stop there. The specific guidelines that I listed a number of bullets in the document about specific things you can do in terms of who should be excluded and washing hands and using gloves, but all that's pretty garden variety standard stuff that won't surprise anybody.
Dr. Macy's, do you share a similar view? Would you like to comment on that?
Yes, no, I again commend all of the participants in the webinar to Dr. Hansfield's extremely well-written and well-reasoned approach to making the decision. And I would only perhaps amplify it in a couple of ways. First, I think that, as he mentioned, if the notion of the question of restarting passenger carrying operations would really be relatively simple if VPOs had the ability to do economical same-day testing of aircrew and passengers for virus RNA and have the results available prior to departure. Wouldn't life be wonderful, you know? And so we have to use a kind of risk-based approach. And in that regard, I've had the privilege of participating for about the last 20 years on a number of NASA advisory committees related to human health risk, both of terrestrial and space flight. And I've been impressed that as an organization that engages in high-risk flight operations, they use a risk management strategy that's based on a two-part model, and that is an attempt to quantify the likelihood of an adverse event occurring, combining that with the severity of the consequences when that event does occur. So they, for example, would tolerate common events that do not have serious endangerment of mission capabilities, at the same time being intolerant of even exceptionally rare events that would result in a loss of a critical mission capability or loss of life. And that it may be useful for BPOs to have a kind of approach to risk stratification that is based on, as is described in Dr. Hansfield's paper, a set of, at the core, what might be considered no-fly rules, right? And so in my supplementary document, just as Dr. Hansfield mentioned, the list includes no person, either air crew or passenger, who has an active respiratory infection, no prior exposure to COVID-19 in 2 weeks. I would actually add to that, though, that my general view that to the extent that we have risk in the cockpit, it's bidirectional, and it may even be symmetric. So you don't actually know whether it might be the flight crew giving it to the passenger or the passenger giving it to the flight crew. So that I would add perhaps a no-fly rule that includes no pilot or flight crew that is a member of an elevated risk COVID-19 risk outcomes group as defined by CDC. I'll talk a little more about that. And no pilot or flight crew member who is either unable or unwilling to wear a surgical mask because they find them unacceptable personal safety issue. And all of your pilots should check this out. They should actually put one of those masks on and go try to fly an airplane, because it's not easy. And not all of them may be willing to accept that key prevention measure. Then, so beyond a kind of core set of no-flight rules, then it seems to me there may be a middle ground where you know you have missions that are associated with elevated risk of a virus transmission, and the organization would maybe both the passenger and the pilot and the VPO are willing to accept that risk. And for that, you might want to add an additional layer of a kind of independent reviewer who is not have a kind of conflict of interest of wanting the patient to arrive in the clinic, and so they want them to be transported, not actually knowing what the overall balance of risk is. And for that, as I say, just having some kind of mid-range risk stratification where you get a little extra, one extra opinion, so to speak, before you fly. And if the VPO finds that an attractive proposition, that a good way to anchor that would to be use the CDC COVID-19 list of conditions that confer elevated likelihood of severe or fatal outcomes. In my paper, I have a list of them, as you might imagine. It's people 65 and older, those who come from nursing homes or long-term care facilities, chronic lung disease, serious heart conditions, patients who are immunocompromised, severe obesity, diabetes, particularly uncontrolled diabetes, chronic kidney disease, people with liver disease. So if you use that as a kind of core list of these people that may be in this middle range of risk where you want to do additional review, that might be a way to do some stratification where it isn't not simply as we just fly with a checklist or we don't fly, and there's no kind of middle ground for expert judgment to help make the decision. And I'll stop there. Thank you.
Thank you. That's actually a good segue to Dr. Kazmi. I wanted to give you some time before you have to jump off, because you represent a population that many of our volunteer pilot organizations serve, which is patients who are immune compromised. So can you tell us a little bit about the risk of someone who is immune compromised, say a chemotherapy patient, of contracting COVID-19 versus the risks of maybe not being able to access their treatment?
Thank you. And I really do appreciate Dr. Hansfield's comments specifically about not making travel through these volunteer pilot organizations be more stringent in regulation than, hey, say the general FAA guidelines, or really what even the medical community believes, because really access to care is a big concern. So whereas everyone wants to be completely safe, and the only safest place for you to be is in your home, not going anywhere, everything else involves some degree of risk. And in what I do, and I'm a practicing oncologist who treats lung cancer primarily, the risk threshold is quite high of not getting treatment. So these are not patients often who have the luxury to delay care. Nothing about what we do with active cancer treatment is elective by definition. And so these patients actually run the risk of increased mortality and definitely increased morbidity if they delay their therapies. So with that in mind, I will have to say that our biggest concern is the fact that these patients may be on chemotherapy and other therapies that make their immune system compromised. And we know from a lot of data from China, as well as now from the US, that patients who have lung disease, any kind of lung disease, so COPD, lung compromise, emphysema, and certainly lung cancer and other lung pathologies are at higher risk of complications from COVID-19, and thus higher risk of mortality and morbidity from this disease if they were to catch it. So that's a high-risk population by definition. All of my patients are going to be. And so I would hate for them to be excluded from being able to be a passenger because of stringent guidelines excluding high-risk people, because these people, if they don't get their treatments on time, are at almost 100% risk of premature death. So I think that the one person and the one group of people that may really help outline the risk-benefit ratio for that person traveling, that patient traveling, besides all of the precautions, which I completely respect, all of the, wearing the masks, and of course we screen patients 2 to 3 days before they travel by phone and make sure they don't have recent contacts, they don't themselves have symptoms indicative of COVID-19 infection. Beyond that, I would say that the person who's most able to do that risk-benefit analysis of whether it's worth taking that risk to take that flight, which certainly will add the risk of contracting this disease, even if everyone's following all of the rules, is the patient's oncologist. To that end, I could have somebody who is getting scans every 3 months, for instance, who's cured of their lung cancer, had their treatment last year, who could safely delay that visit for another month or two without any inadvertent adverse events to that patient. But I would be the best person as the patient's treating oncologist to say, hey, this person shouldn't travel right now in the pandemic and can wait 2 months, or Mr. X has chemo needs. He has a massive tumor in his lung and his liver, and if he doesn't get this treatment or he gets delayed 2 weeks, he's going to get admitted to a hospital, which is a worse risk for him, and he will get sick. So I think that perhaps the treating facility, the physicians who are taking care of the patient, who actually the patient is going to see, might be the better person to make a risk assessment of what's the benefit of that person traveling and how important it is versus the risk that it's going to have regardless how much precaution you take.
Right. And so on that point, we received a question regarding physician approval letters. So many of these organizations require that before passengers would travel with them, their physician approves them for flight in a small aircraft. Yeah. Would adding a question about COVID-19 risk be something that is worth adding to those? And would you suggest having patients submit new approvals if they haven't traveled during these times?
I think that, there was a question I saw in the Q&A of who should take that risk on. Is it the pilot's responsibility if something goes awry? Who's the clinical risk taker here? And it should not be the aviation or the pilots who are taking on that risk. It really ought to be the person who's determining that that flight is necessary. And it's really the treating physician. So I think that anywhere in that form, there should be that the physician's team had a discussion with the patient, both themselves as well as the patient understand the risk and still believe that that flight is necessary regardless of the risk it poses. And it certainly poses a risk, even if it is attenuated by all of the precautionary measures. In that case, I think everyone might be better protected, so that conversation is forcibly documented. And then you have that piece of paper to say, hey, if anything goes wrong, the person does get sick. In hindsight, you're not going to question that decision because it was made proactively.
Right.
I would concur, if I could comment, everybody, that I agree that the pilot alone need not make the decision. I can sort of speak for Angel Flight West, not formally because I'm not formally associated except as a volunteer pilot anymore, no longer on the board. But I think the same applies to other Angel Flight, probably other VPOs, is that the coordination desk already goes through a process of what's the nature of the medical problem, what are their concerns about the safety of travel, which might most commonly up till now have been, does this person need supplemental oxygen, for example, during travel? Is this person safe to travel in small aircraft? I think it would not be difficult for the coordinators to have an additional set of questions. And to some extent, they will also communicate, as we just heard, with the oncologist or other physician, if it's pediatric surgery or whatever it might be, about the physician or the clinic's perception of what the risks are. I would prefer that sort of process to Dr. Macy's proposal of having a, quote, third party. Adding still another layer in there sounds to me like it could be overly cumbersome. But the notion that the pilot alone is not responsible, but that there is these coordination efforts with the provider makes a lot of sense to me.
If I can just jump in for a second. What I'd say is that also we're at a moment in time right now where testing is not necessarily reliable or widespread, but that will come soon, as was discussed earlier. And when that comes, and then the whole calculation will change as well. So, of course, as Dr. Macy has said, that there could be symmetrical risk here. Of course, if the patient themselves is someone who has lung cancer and is a particularly high risk, the risk of getting COVID-19 or of having a negative outcome of getting it would be higher for the patient per se. But we have to assume that all of us could be asymptomatic carriers unless we know otherwise. So at some point, when the testing is widely available, then it could happen prior to a movement that the pilot and or the patient is tested, both to find out, number one, if they have it at this moment, and number two, if they have antibodies. And it's still not known yet about the antibodies and how much immunity comes with that, although more and more data is coming in all the time. And once that's available, if we have, for example, a pilot that in fact has a test showing that he or she has antibodies, and we later know that yields some comforting degree of immunity, then that changes the whole calculation.
And in the meantime, we've got to think about what we can do. There's a lot of talk about personal protective equipment and wearing masks. Can you talk a little bit about how effective that is, and if it's something that passengers and pilots should be doing?
Who are you asking?
I'm asking Dr. Flame, sorry.
Yeah,
I'm happy to start off, and we can pass it around. Yeah, in the first instance, while we're waiting for that spot where testing is widely available, and we are under the assumption that any one of us could be asymptomatically shedding virus and therefore perhaps at risk for infecting the other side, whether I'm a patient or whether I'm a pilot. A number of steps taken. One, as Dr. Cosme stated, there can be some creative means of avoiding a flight in the first instance. Perhaps teleconsultation, a video conference like we're doing now would be a good start. There may be some combination of a patient working in conjunction with teleconsultation with a doctor like Dr. Cosme, and perhaps a local primary doctor who can help administer some tests or an exam or some medications while we're waiting. After that, though, if there's a determination that the patient really should fly, then using all of the precautions that we normally would take would be great. And then we have to really take a look at the practicality of that for the purpose of this conversation for volunteer pilots and likely small aircraft where you may be within 6 feet of your pilot or of your patient, what's involved there. So wearing a mask while flying may be difficult for pilots. If pilots are not used to doing that, then we don't want to put them in any degree of danger if they're trying for something for the first time with a passenger and not used to that. But I'll pass on to any of the other panelists.
For what it is worth, I have gone through the exercise of flying with a surgical mask in place, and I don't find it very obtrusive in terms of communication. I probably need to enunciate a little bit more clearly on the radio because of the barrier between my mouth and the microphone, but it doesn't seem to be a serious limitation. I would repeat one of the points that I glossed over maybe too quickly in my introductory comments, that there are going to be individuals who need to get to medical care, whose health risks, if they do not achieve that care, are sufficiently serious that the pilot and the VPO together may decide that it is worth whatever small risk exists. Yes, people can be asymptomatically infected, but if they don't have symptoms and are not coughing, the likelihood that they are going to transmit or be highly infectious while wearing a mask and while not coughing and so on is low, even if people are infected. So I think my guess is we're going to see a number of volunteer humanitarian missions by various ACA affiliated organizations and their pilots who are going to make those calculations and decide to make those flights. And I would predict we're going to see a pretty low rate of suspected airborne transmission during these flights. It will not be zero, but it seems to me that there are certainly many, if not all, potential beneficiaries of our services for whom the risk calculation will be and properly should be in favor of making some of these flights.
So there were a lot of...
I put it in PIC context, and it's a combination of the organization, the pilot, and through perhaps the organization, communication with both the traveler and the traveler's healthcare provider, or whatever humanitarian service they're to help participate in that discussion.
Thank you. We did get a lot of questions that were sort of aircraft specific. Dr. Macy, would you be able to just give your insight on whether there is sort of a best case scenario aircraft or alternatively a worst case scenario aircraft? People are wondering if it's reasonable to suggest assigning flights to pilots with larger equipment like turboprop or jet aircraft where possible.
Yes, and so I think actually I could address both ends of the spectrum. I think pretty clearly the worst case is a small 2-seat aircraft that puts people shoulder to shoulder and no ability to do any kind of respiratory isolation. And the best case, which was amplified this morning by a friend who is a Boeing 787 pilot who flies international routes for United, was the guidance provided by United Airlines to all of its pilots in mid-April, answering the question of the safety of cabin recirculation fans and how they should be set, noting that all of their aircraft, which include both Boeing and Airbus, transport category aircraft, have rapid exchange air filtration systems with HEPA filters that are more than 99% effective against viruses. And so they actually have their standard operating procedures set already to maintain the best air quality with the least particulates. So that, I think, combined with the availability of a lot of empty seats on airliners, makes them a clearly preferred option in terms of reducing the risks that we know about that require distancing and air recirculation. The middle range aircraft, and Dr. Slame and I talked a bit about this, are a kind of a blind spot for those of us who are panelists. And that is, I have a small amount of time as a second officer on turboprops, and there are a lot of biz jets, small kind of 6, 8, even the microjet variety of business aircraft, where we simply do not know the air handling systems or such. So I think for that middle category of transport in between airliners and airplanes that are impossibly small, there's ample ground to actually learn about the particular airplane that's going to fly and what its air handling characteristics are. But apropos of Dr. Hansfield's initial remarks, it seems it would be highly unlikely to be less safe than the 4 to 6 seat general aviation aircraft that just has its vents open for air circulation. I'll stop there.
And in the context of travel in a typical small 4 to 6 seat aircraft where we know it's not possible to social distance, does the usage of PPE still make sense? Is it still relevant, or does it not matter because it's such a cramped space? Dr. Hansfield, do you have any thoughts on that? You're on mute.
Sorry, I had temporarily muted myself. I think it does matter. I certainly think that the surgical mask makes sense to the extent that for some reason physical contact with a traveler between a pilot or aircrew and traveler becomes necessary. I think wearing nitrile gloves for physical contact makes sense. I think if in aiding someone in and out of the airplane, gloves aren't available, and certainly after that touching, hand sanitizer or hand washing makes sense. Personal protective equipment of the sort used in healthcare settings, that is wearing plastic gowns and that sort of thing, is clearly not practical. But I do think the physical distancing, gloving selectively when there has to be physical contact using surgical masks should be used in that environment. I agree that because of the physical size of the space raises eyebrows and creates potential alarm. And I cannot say that my Cessna 182 cabin would be anything like risk-free. On the other hand, with the vents open, the air flows quite through. I can control temperature and airflow. I can make it too cold really quickly or too hot really quickly for folks. And there's clearly a lot of air exchange going on. And if you were sitting inside a closet with no air circulation whatsoever, I would put that in a pretty high risk category, even if someone was asymptomatic but infected. My sense is, not being an expert in all small GA aircraft by any means, that at least in my airplane, there's probably enough air circulation that the risk would be a lot lower than in a truly closed, non-air circulating environment.
Thank you.
And again, I'm guessing.
Dr. Slame, there was a question about whether or not risk increases as flight duration increases, and if so, should precautions be different for different durations? For example, a 1-hour flight versus a 3-hour flight.
Right.
Can you provide any insight?
Yeah, I'm happy to answer that, and then I know Dr. Macy's had a point he wanted to make too, so I'll switch over to him after I finish this point. But the factors, some of the factors that I'd consider here are the proximity between the pilot and the patient and/or passengers, the duration of the flight, and also the air circulation that was discussed there as well. So in commercial aviation, the air may circulate 20 to 30 times an hour, versus in a regular office building that could be 6 to 8 times an hour. So that's in commercial aviation. In fact, the flight itself, just in regards to that piece alone, may have some degree of safety. There's plenty of other risks, like being at the gate, waiting in line, taking the transportation to the airport, but that alone may be helpful. If you're flying a mission that is a half hour long versus one that is 3 hours long, in theory, someone who's shedding some degree of virus you'd come into more contact with that the longer the mission. If you're able to control the ventilation though, that's all very helpful. So I think what we're doing is, as we've all discussed here, is not coming up with zero risk, but anything we can do to decrease the risk would be helpful. Therefore, I would think in general, larger aircraft. But I'd like to go back to Dr. Macy's because you looked like you had something that you wanted to share. And you're on mute still. Thanks.
Okay. Yeah. So thank you, Dr. Slame. And this was actually just a personal observation about the issue of mask protection is effectively thwarted on the West Coast by our having an awful lot of tall timber where the minimum en routes, especially if you're IFR, are oxygen level altitudes. And in my own plane, I'm accustomed to using nasal prongs. I have not been able to consider a way that you could combine a surgical mask and nasal prongs that is sensible. However, what I have discovered is that I have actually a mountain high digital oxygen system that has the high altitude mask. So the aviation oxygen mask, which has the built-in microphone, even if you don't turn on the oxygen for it at a low altitude, actually is a very effective droplet trapping device, and it overcomes this problem as you transition to oxygen altitudes of wondering what the heck you're going to do with your surgical mask when you ask everybody in the cabin to put on their O2 in an unpressurized setting. So that's just a hint that I think other people might want to consider if they happen to have the kind of full face aviator oxygen mask with a built-in microphone.
And I just want to comment too, I think it's correct that our focus should be on breathing and air circulation right now as well. We don't want to forget some of the basics of transmission and interrupting that whole cycle where with the respiratory droplets that land on a surface that we touch with our hand, and then we take that hand and we rub our eyes, nose, or mouth, and we effectively put it in ourselves, or my unknown, if I'm asymptomatic shedder and my unknown respiratory droplets, even coming if I'm not coughing or sneezing, can inadvertently come out and find its way to a surface, over to a hand, over to the person's eyes, nose, or mouth. So interrupting that with common sense hand washing and avoidance of touching your face during that time, and a reminder to all parties before a flight would probably go a long way to make a difference.
Question about the small pressurized aircraft. Would it be better to not recirculate the air, as you would not be simply keeping the virus in the air for longer, as the air does not leave the aircraft at any really high rate of exchange? Does anybody want to address that? Better to not.
I will only say that all of my comments and all of my personal experience are in regard to non-pressurized aircraft. I do not know what I take the principle that in a pressurized aircraft there's probably more closed air circulation than otherwise. On the other hand, for most humanitarian flights, although obviously sometimes you're going to need oxygen and need pressurization if you're going over the top of Colorado or the Sierra. On the other hand, it's probably possible for many of these flights to stay down below 8,000 or so, and perhaps leave the pressurization off if that increases air circulation. But I don't know the mechanics of how that works in pressurized aircraft.
We had several questions come in about the masks. Are surgical masks the only appropriate type of mask? What about cloth masks? Do they increase the risk? Does anybody want to speak to that? Dr. Slame?
I'll take a quick start at it, and we can go over to Dr. Hansfield afterwards. You know, if we're looking at protecting ourselves from having the virus enter our nose and mouth through breathing it in, then in that unique situation, we're talking about N95 masks. But that is really reserved for a medical environment. So when we're talking about wearing surgical masks or cloth masks, in fact, much of the time what we're talking about is protecting other people from ourselves. So, so to that extent, the CDC and the WHO have advised that cloth masks are fine. In regards to the differences in the effectiveness between a cloth mask and a surgical mask, there's a lot of variables, including how well somebody actually uses them. If they take them off, put them on, reverse them, touch the outside, touch their face, then it all becomes less effective. So let me hand back to Dr. Hansfield and see if you.
I would just say that I agree 100%. There are no, to my knowledge, there are no systematic scientific data that address these issues. Logically, CDC has decided that any barrier that puts cloth in front of your face is going to some extent, reduce droplet expulsion and probably larger aerosol particles from escaping the mouth and nasal and nose of infected people. How effective truly they are is not established scientifically, and it might be a long time before we're able to do that. It makes common sense, and my personal inclination is to, if you have it available, to get a supply of surgical style masks and use those and offer them to your passengers. If those are not available, then a bandana over the nose and mouth is probably a lot better than nothing.
We have a few questions that came in regarding people who work around COVID-19 positive patients, like doctors and nurses. Does that in and of itself eliminate them from being able to conduct angel flights? Does it make them more risky? Do you have any thoughts on that, Dr. Macy's? You're on mute.
Yeah. I think it, in an unquantifiable way, it obviously raises the issue of recent exposure and this increasingly well-recognized period of virus shedding that begins before those who are symptomatic become symptomatic, and then a smaller fraction of people who remain asymptomatic. So I think that is a difficult judgment call. Certainly by the list that Dr. Hansfield provides, it would in fact be an exclusion both for a pilot and a passenger. Others may have a different take on that.
What is the known incubation time between a person's exposure to the virus and their ability to transmit it?
The rough timeline is, if acquisition is time 0, probably most people have isolatable virus or identifiable viral genetic material in their nose and mouth within 2 or 3 days after that. In another couple of days, they will start to develop symptoms. The viral load is rising at this period of time. And then after symptoms start, the viral load, the amount of virus, then begins to decline. Now, when I say these number of days and that sort of thing, it's really a wide range. Though there's statistical averages, it undoubtedly takes longer in some people as others, and viral shedding may continue longer in some others. A total unknown at this point is the extent to which the dose of virus to which one is exposed increases the likelihood of infection or of symptoms. One hypothesis for the dramatic level of illness and mortality in skilled nursing facilities is that for a long period of time, and to some extent still in some facilities, staff weren't taking proper precautions, and these patients were getting repeatedly exposed and perhaps had large inoculums of virus that had worse impact, particularly in a highly vulnerable population by age and underlying medical conditions. So dose of virus may make a difference, but we don't really know for sure. Areas of active research.
We have a question related to geography. When considering whether to volunteer for a mission, do pilots need to consider specific locations more carefully? In other words, should pilots in low impact areas more carefully consider a mission to a high impact destination or vice versa.
Let me comment first, just because I mentioned this specifically in my essay, and I simply pointed out that pilots will naturally have different levels of personal tolerance, and it would be entirely understandable if some pilots would be more wary of transporting someone from urban New York City currently, for example, than rural Colorado, to pick something perhaps at the other end of the spectrum. That's an entirely reasonable factor, something to factor in, but I wouldn't make a rigid rule that says geographic area A versus B are or are not going to be our customers for humanitarian missions.
Dr. Salam, you deal with cases from all over the world. Do you want to comment on that as well?
Yeah, I'll bring up two principles here. One is we want to think about what is the risk where you're starting and what is the risk where you're ending. And if those risks are the same, then it may not make much of a difference. So if you happen to be in a medium risk location and you're going to go to a medium risk location, and you are going to and you're already out and there's some degree of physical distancing restrictions that have been lifting that all parties have started to engage in, then there wouldn't be any difference, frankly, in flying that route, other than you're with your pilot or with your passengers in a closed space for some period of time. So if you're traveling from let's say a very low risk location to a high risk location, then you've increased your risk. I also mentioned there's a lot of places in the world, first started in China, but now in other locations, where they're using some degree of a color-coded system, a green, yellow, and red identification zone. And that is only as good as the availability and reliability of testing exist in that area. But in China, for example, they do color code each area, and if an area is designated as red or significantly higher risk, then they clamp down on the travel to and from those locations. If it's in a location that they've done widespread testing, and in fact the number of new cases per day and the number of total cases that exist there, and the availability of other things like hospital resources are low, then they do allow travel in there, and it's a lower risk. So all this goes back to the point both made by Dr. Macy and Dr. Hansfield before about the decision that pilots make and when they throw all their risks into consideration.
Thank you. So the federal government and many states have now announced plans for reopening and their phased plans. Does it make sense for these organizations to also resume service in phases? And if so, what would that look like? Dr. Hansfield, do you want to address that one?
Well, I'm just thinking, I think it does make sense, but whether rigid rules or policies or standards can be set up, I'm not sure. The color coding idea strikes me as something that could be applied by humanitarian services, VPOs. And I would imagine that if, for example, if Angel Flight East or West opens up and starts transporting more customers in the not too distant future, that some patients are going to be higher priority. As we heard earlier, if someone's got a medical condition that's going to be very harmful if they don't get care soon, we're going to have a different threshold than if they're not in such dire straits. I think it's important for all to keep in mind, at least in the medical context, that one of the impacts of COVID societally is the reduced quality of care and perhaps increased mortality from a whole host of medical conditions other than COVID itself. And it's part of the VPO's responsibility to be contributors to ameliorating that outcome.
Thank you. We've got about 5 minutes left, and I wanted to address something that came up a lot from our attendees, which was with regard to cleaning the aircraft or disinfecting the aircraft. A lot of charter operators are sort of advertising that they're treating the interior of the aircraft with antimicrobial agents. Does anybody know about whether that's effective or if it's something that can be applied on a smaller scale for volunteer pilots?
Yeah, so I'll take a first pass at that. Others may wish to participate. So the EPA has a list of, if you will, vetted or approved cleaners and disinfectants. and that would be a reasonable place to start. I don't believe that any particular operator has a magic solution that's any better than these disinfecting agents, which are either based on soap or they are based on alcohol at concentrations to 70% or greater. So I think for VPOs, it would be reasonable to use the EPA list for solutions that can be used on impervious surfaces. So I'd be very careful about putting bleach containing products on fabrics. And with respect to the pilot's front office, glass cockpits that have touchscreen displays, each of the manufacturers of those has their own specific recommendations for their equipment. Although as I've looked at them, almost all of them tend to be alcohol-based solutions. And then I think for the flight controls, the yoke, the throttle, the prop, all those sorts of things, that 70% or better alcohol products are probably a reasonable first approximation of a pretty good way of staying safe there.
Thank you.
I'll just add that societal standards are now that environmental cleaning of this sort is going to be expected, and you're going to have to do it even if scientifically it doesn't always make a lot of sense, because people are going to expect it, and it's just common sense. There was a nice article in the New York Times 10 or 14 days ago pointing out that there is some controversy about this. The number of cases that are actually known to have been acquired through environmental contamination as opposed to more direct airborne contact with an infected person is simply unknown and probably low. Whether Costco and other places need to be sending employees around doing all the wiping down they're doing, whether it's a good idea or not, scientifically isn't clear, but it's a standard. In aircraft, I would at least emphasize alcohol based solutions on those things that people handle on a regular basis. Obviously, headsets. I personally would probably get a handful of fresh headset microphone muffs and use a fresh one for every person using it. I would certainly clean the headsets very well. I would wipe down seatbelt buckles and doorknobs and door handles and anything else. What to do about leather and cloth in the airplane is a little bit more difficult in a small general aviation aircraft. But I would at least start with those frequently touched items.
Thank you. We just about run out of time. I know that hour went really quickly. I'd like to thank all of our panelists for giving your time and your expertise today to help educate us, and also our attendees for tuning in and engaging in this discussion. As a reminder, this webinar, it has been recorded and we'll be sharing it on our website, so that'll be available to you. I know there were a lot of questions and we may not have gotten to all of them. If we didn't get to yours, feel free to email me at k.luke@aircarealliance.org. Both Dr. Macy's and Dr. Hansfield's papers, along with a lot of other resources, have been posted at our website. And be sure to follow us on Facebook to find out about upcoming webinars and information related to public benefit flying. Thank you, everyone. Be safe, and we'll see you next time.
Thank you.
Thanks, everybody. Feel free to email. Find our email addresses, send messages. It's okay.
Yep.
That's great. Thank you, everyone.
All right, be safe.